able to put in more focus on. Hi, thanks for being here. I don't think we properly let everybody know what the title of this session would be, but we're going to focus on post-pancreatectomy acute pancreatitis, something that is totally non-controversial. I'd say that tongue-in-cheek, obviously, but it's a moving target, and we've been interested in this topic in the HPB Collaborative for a while. And I'll just start a little bit by going over, come on in, where the collaborative stands and what it stands for. And then we figured out today that Dr. Zyromsky is double booked this hour, but one of the new faculty at IU who's been involved with a lot of their work, which is a key part of this presentation, Dr. Rocha will be giving that part of the presentation. And then Brian Braychek, who was a clinical scholar at the college, did an analysis with people from the college and me about the differential between serum amylase and drain amylase. And I'll present a little bit of that. This same presentation has been given a couple of times over the last few weeks as a webinar through the college, but those webinars are during the day and they're primarily attended by the surgical clinical reviewers as opposed to the HPB surgeons. So that's why we wanted to present that information again here today. So the overview of this hour will be my update of the collaborative, Alex's talk about post-pancreatectomy acute pancreatitis, and then I'll present a little bit about the differential between serum and drain amylase, and ideally we can have a good conversation. And in my experience, usually we get people wandering in as we go. So this collaborative's been going on for 8 or 9 years now, and we've had the goals to encourage quality improvement initiatives, which engage with engagement of HPV surgeons, NSQIP surgeon champions, and surgical clinical reviewers. This has been a great partnership between the American College of Surgeons and the AHPBA. We want to reduce variation among hospitals and HPV surgeons, provide a forum to share and disseminate best practices, and the ultimate goal, obviously, is to improve the outcomes for our patients. Now, this graph shows kind of where we have grown within NSQIP with respect to procedure-targeted hepatectomy there in the red bars and pancreatectomy in the right bars. And this shows what has happened over 11 years. We actually did a demonstration project in pancreatectomy in 2012. These variables were optional in 2013. They were required in 2014. And I think you can see we've really grown a lot over time. And this year we have 185 hospitals literally around the world who are targeting either pancreatectomy and or hepatectomy. Most are in the US. We have 10 hospitals in Canada, 10 in Australia now, and a few in the Middle East and a few in Southeast Asia. So this is truly an international effort. And I'm not going to present the data today, but Joel Bean and others and I have published a couple of papers that have shown even in the first few years between 2014 and 2018 that we improved the morbidity of pancreatectomy and hepatectomy in North America. So we are making some progress. Now, this is information from the last semi-annual report that literally came out 2 weeks ago, and there's always a little bit delay. It's a 12-month period. This one went from July of 2011 through June of 2012, and even though that was still, if you will, in a little bit of the COVID era, we gathered data on over 5,000 hepatectomies and over 7,500 pancreatectomies, which we believe is at least 2/3 of those operations in North America that we're gathering data on. There are a lot more partial hepatectomies than major hepatectomies, and about 2/3 of the pancreatectomies are Whipples as opposed to distals. And these are the reports that come out semi-annually for the 100+ hospitals who are technically part of the collaborative, and they account for between 80 and 85% of all the operations. And it gives you your data vis-a-vis everybody else who's in the collaborative. So whether you are really good at delayed gastric emptying or not so good at clinically relevant post-pancreatic fistulas, or really good at bile leaks but not so good at post-hepatectomy liver failure, as examples above and beyond all the usual NSQIP data. And I'm a big believer that just the feedback of that data and the desire of all of us to do as well as we possibly can for our patients is what helps drive the improvement in outcomes. So just a little bit more information. Overall morbidity for hepatectomy on the left and pancreatectomy on the right, obviously is greater for major hepatectomy and for Whipple procedures. But interestingly, the overall morbidity for distal pancreatectomies is almost equal to that for major hepatectomies. And this is just the specific NSQIP definition of overall morbidity. When you add on the procedure-specific things like post-hepatectomy liver failure or clinically relevant pancreatic fistulas, those rates go up dramatically. The overall SSI rates have been a focus for us, and while we have made some improvements over time, there's a big link here with things like bile leaks and pancreatic leaks, where perhaps we still have a lot of room for improvement. But as you can see, we still have about a 20% overall SSI rate for Whipples and about a 14% for major hepatectomy. And then when we break those down, you can see that the superficial SSIs are not so bad. 3% for major hepatectomy, 5% for Whipples. 8 or 9 years ago, the superficial SSI rate for Whipples was 10%. So we've cut that in half over time. But the organ space infections and the pancreatic fistulas remain our Achilles heel. So here's more information on the bile leaks and the pancreatic fistulas. Again, for hepatectomy, a lot more bile leaks with major than with partial. We were down into the 13% range for clinically relevant pancreatic fistulas a year or two ago. Those have inched up a little bit this last year. Having said all of that, this is what I really want to focus on here. So we started putting data on serum amylase into this platform a few years back, and this was before the International Study Group defined what we're going to talk about. And for that academic year, if you will, from 21 to 22, not everybody was measuring serum amylase. And this was a pretty open definition. Did you have any data on post-op day 0 or 1? And only 14% of people of cases had a serum amylase measured for Whipple, and only 9.5% for distal pancreatectomy. Interestingly, when the levels were measured for Whipple, 74% of the time the levels were elevated, and for distal 65%, and the median number was 315. probably a little bit more than 3 times the upper limit of normal for Whipple and 180 for distal. And then, as you'll see, as I finish up this presentation later, the grade B and C hyperamylasemia, as we defined it a few years ago before the international study group, was present 25-30% of the time when there was serum amylase measured. So since then, we tweaked this measure once to say, okay, it could be amylase or lipase, and okay, we want to know the number as well as whether or not it was drawn. And then more recently, we've tweaked the definition to emulate the International Study Group of Pancreatic Surgery definition that was just published in Annals less than a year ago. So with that background about the collaborative, Dr. Zaromsky was the presenter of these data at our webinars a couple of weeks ago, but Dr. Roach will give us an update because she's been intimately involved with this topic at IU over the last few years. Alex?
Good afternoon. So I have big shoes to fill, but I'm going to do my best. We've worked for several years on that topic at IU. So just a brief definition and introduction. There's like a lot of patients. I don't know if you check the serum amylase in those people, but an elevation in serum amylase following a Whipple procedure is actually a common finding. We don't know at this point, or at least we didn't know, the clinical relevance of postoperative serum hyperamylasemia, which is actually now in the definition POH, not POSH. And in recent work that was published last year from the International Study Group for Pancreatic Surgery, there's a standardized definition for postoperative post-pancreatectomy acute pancreatitis. So a brief overview of the talk. The first one would be to define acute pancreatitis, just a mere review. Definition and overview of post-pancreatectomy acute pancreatitis, then our data at IU, and then the definition that was published by the International Study Group last year. So just everybody in this room knows, but acute pancreatitis, the definition and the classification is from 2012 from the Atlanta classification. So you need 2 of the 3 features, which is abdominal pain consistent with acute pancreatitis, which is the epigastric radiating to the back, then a serum amylase or lipase at least 3 times the upper limit of normal, and then a CT that shows findings consistent with acute pancreatitis. So this is a CT from Dr. Zaromsky's patient. He published this in 2010 because at this time, so I had a chance to discuss with him, and he said this time he was not sure that that actually was a finding and that patients post-Whipple could have acute pancreatitis, and his patient developed necrotizing pancreatitis post-Whipple. So the first line is post-operative day 17 after Whipple. The patient had necrotizing pancreatitis, as you see, with some fluid, peripancreatic fluid collection, and then the CTs, the second line and third line of CTs shows progressive resolution of the pancreatic collection. So the definition is still evolving, and even if the International Study Group published something last year, it's still very debated. So as we currently see it, the pain, which is part of the definition of post-pancreatectomy acute pancreatitis, is not really reliable. I don't think that anybody sees a patient post-op day 2 of a Whipple with no pain. The enzymes, so right now it would be 3 times the upper limit of normal, but again, there is some debate about that. The radiology finding, which is present in the definition, it was the most debated part of the definition from the International Study Group. It was pushed mostly by the Heidelberg group, for which it was very important. But I don't know how many of you do actually a CT on post-op day 2 of a Whipple just to confirm that they have acute pancreatitis. The mechanism of post-pancreatectomy acute pancreatitis, it's probably multifactorial. Dr. Saxon Connor described some ischemic changes. There may be some technical factor as to the way you're doing your anastomosis. I know that I do the Bloomgard-Kelly technique. Most people don't. So is it just like crushing the gland, causing more acute pancreatitis? And clear the gland factors. Is there some underlying cellular changes or genetic predisposition, or patients that had neoadjuvant chemotherapy? Is it something that we need to think about? So this is a paper from the Verona group published recently that shows that there's an association between post-pancreatectomy, acute pancreatitis, and major morbidity. And it's also an independent predictive factor for postoperative pancreatic fistula. So a correlation with increased mortality as well. So the next few slides are actually our work at Indiana University. Our hypothesis was that an increase in serum amylase over 3 times the upper limit of normal after Whipple procedure indicates post-pancreatectomy or post-operative acute pancreatitis and is associated with an increase in post-operative morbidity. We had a total of 677 patients undergoing a Whipple from 2013 to 2019. And we measured the serum and the drain amylase between post-op day 1 and post-op day 3. So upper limit of normal, everything below is considered normal. Then between 1 and 3, it's considered just post-operative hyperamylasemia. And then above 3, it was considered post-operative or post-pancreatectomy acute pancreatitis. The incidence of postoperative hyperamylasemia and acute pancreatitis was actually just determined on 415 patients because for the remainder, we didn't have data on the serum amylase. So in almost a little bit over half of them, it was normal. 23% had an elevation that was between 1 and 3, so postoperative hyperamylasemia, and 18% had what we called post-pancreatectomy acute pancreatitis with an elevation above 3 times the upper limit of normal. So this is what we see every day, and we find it very interesting, is that both the serum and the drain amylase are extremely elevated initially, but they trend down very rapidly. So I know the definition from the International Study Group is three days, but we feel that on post-op day 1, it's extremely elevated. On post-op day 3, it may be like almost close to normal. And both the drain and the serum amylase are extremely elevated and trend down and normalize extremely rapidly. This slide is what differentiated our work from the previous work. Is like we had both the serum hyperamylasemia and the drain hyperamylasemia, and there was no correlation between the two. So you can see whether it's the definition of postoperative hyperamylasemia or postoperative acute pancreatitis, there was no correlation with the drain amylase, as you see on the correlation coefficient R2. So this is just something that makes sense is if you think about the fistula risk score, which is like the pancreatic gland texture and the duct size, among others, it's intimately associated with postoperative hyperamylasemia and acute pancreatitis, and that makes sense, right? So on the left side, you have the association between the post-operative hyperamylasemia and acute pancreatitis and the gland texture, and on the right side with the pancreatic duct. And you see the harder the gland, the less likely to have hyperamylasemia or acute pancreatitis, and the smaller the duct, the more likely to have acute pancreatitis or hyperamylasemia, and that makes sense. So then we studied if an increase in postoperative serum amylase is actually a predictor of morbidity, and it is across the board for any morbidity, major morbidity, pancreatic fistula, delayed gastric emptying, and any type of surgical site infection, whether it's superficial or deep. It was not associated with a change in mortality, but that may just be a lack in power. So what was interesting is that any elevation, whether it's 1 time, 2 time, 3 times in serum, in postoperative serum amylase was actually predictive of morbidity. And there was no difference whether you consider a cutoff of 1 time the upper limit of normal or 3 times the upper limit of normal. So in conclusion, we wanted to make sure that the serum amylase is distinct from the drain amylase, and Dr. Pitt is going to give a talk about that difference and how it was studied. And any increase in serum amylase above the upper limit of normal is associated with morbidity after pancreatectomy. And whether it's 1 time or 3 times, like the definition from the International Study Group is actually in our institution, didn't make any difference. And an increase in serum amylase should be considered in postoperative pancreatectomy discovery pathway because it will help in mitigation strategies. So then this is Giovanni Marchigiani from the Verona was in charge of the International Study Group for Pancreatic Surgery and in charge of the definition of the post-pancreatectomy acute pancreatitis. So the consortium met and discussed a lot. And so Dr. Johansky took some screenshot of all the emails that were actually exchanged census that actually most people were not part of the consensus and most people were still debating if the definition was what they wanted. So there's a lot, and it was went on for a long time. But finally, they actually came up with and it definition the question and as of surgery about what would be called post-pancreatectomy acute pancreatitis includes pancreatitis also so like they had done with pediatric or hemorrhage. So as you can see, the postoperative serum hyperamyloidemia (POH) amylase activity that is related to upper limit of normal, and it's the same. And then is what is done for postoperative meaning that if you do nothing about it, then it's going to be grade A, and then if you do see if you do an invasive procedure or you have to actually do something even more invasive. So that's what is the plan right there. Grade B has a clinical feature and has a hypermagnesemia over 3 times the number of normal by some medical treatment or some IR procedure. But it is a lifetime condition and requires treatment requires you know. So is that pathways where people have pancreatitis that's for the course. As it is right now from the international a lot of people agree on the entire 3 pillars of the definition, but I think that we can work on the trust. The question is that what are we going to do with that blood culture? Are we going to have mitigate and do we actually include it in our current practice?
Thank you, Alex. So why don't we actually pause there and just open this for questions or comments or discussion about this new definition of post-pancreatectomy acute pancreatitis and the work that was done at IU. Thoughts, questions? Yes. Yeah, so probably that patient had, perioperative hyperamycemia. Probably had you done a CAT scan at day 4 or 5 or 6, you would have seen something, and you're talking about down the road when you figured it out. And I'd say we in North America haven't been great at checking serum amylase, very routinely. I mean, we're finally getting to check drain amylase a little bit more often than we used to a decade ago, but still not everybody's even doing that. The Dutch published the Porsche trial a year or so ago, I'm pretty sure in the Lancet. And they've gotten pancreatic surgery down to just 16 institutions. And in this trial, it was a step wedge trial where they had data before implementation of a standardized postoperative management scheme, and then after, and they, got that gradually over, like 9 months through all 16 hospitals. And in that, they had to check serum amylase perioperatively, see the active protein, obviously they're checking the vital signs. And like day 4, if those things were not right, they mandated a CAT scan early. And if the CAT scan showed something, they mandated at a minimum slow down, maybe start some antibiotics, and if there was a correction, rather than potentially operating out at 2 weeks, try to drain that early percutaneously. With the NISQIP data, we had actually looked at a failure to rescue group of patients across the Atlantic and showed that it's sort of safer if it's not an emergency situation to percutaneously drain these collections rather than go back to the OR early. So, part of what we're trying to do is to get everybody to, at a minimum, check your serum amylases a couple of times. Alex, thoughts, comments?
Yeah, it's probably acute pancreatitis post-op, and it's associated with increased risk of cholesterol. Whether you figure it out early or late, it's the same evolution. Remember that spondylar necrotizing pancreatitis, which is the ultimate. But I would say it always starts with acute pancreatitis. Why the glands only have acute inflammation when you fight very multifactorial, but I would say it's more that transition from pancreatitis to fistula than the opposite.
What kind of stent what are you talking about? I'm sure you know, I mean, there are randomized trials of stent versus no stent at the time of pancreatitis, and in general, there has been no benefit. Some of the data from Japan, where you have an external pancreatic stent after a Whipple, have shown some benefit. So, I mean, we don't have that detailed information, so I can't answer it from the NISQIP data.
I know for sure that we had a similar problem. External stent, a soft gland, like we try to mitigate. So soft gland, usually in those situations, the patient has hepatitis to stop, and we found one. But I don't know if it's because of the stomach, because the gland was at risk anyway. You have you have a small butt, you have someone who doesn't have chronic pancreatitis, because they have a cancer is at first. So then is it because of your steroids and because of other factors around it? It's possible.
So it's routine serum amylase post-op dose 0 or 1. Okay, so a pretty good group. And again, when they did the ultimate wisdom of the group, there are some data from elsewhere that show that it's, quote, sustained hyperamylasemia that is puts you at greatest risk. So how many are measuring it on more than one day? So less a lower group. So we're never going to, see positive answers to that question in our NISQUIP database because nobody's measuring it often enough. And how about C-reactive protein? Who's doing that? One, in Europe, they do that routinely, and I'm more sensitive than white count or amylase. It's something that maybe we should pick up, their thing. And then, how about let's say you're measuring serum amylase early on and it's elevated, and let's say the white count is 14,000 on day 3. And the temperature the night before is 100.8. How are you going to do a CAT scan on day 4? Nobody. And again, this is the definition, that you have to have persistent elevation of serum amylase, and you have a CAT scan that shows something not quite right days 4 to 7. And again, that's what they did in the Dutch trial. And they were able in the Dutch trial to improve they did not reduce the incidence of clinically relevant pancreatic fistula, but they did reduce the mortality of Whipple at the national level, which is very cool. So, I think we need to learn something there.
Just one comment it's about the CRP. I know that the CRP is using colorectal surgery, and our surgeons use it all the time to predict the risk of fistula. So I'm sure that this is relevant for pancreatic fistula as well. It's just that we haven't incorporated it. At least my institution.
I want to just quickly present the project for the college. Vanessa Thompson, Bruce Cliff Carter, worked for the college, and I was part of this analysis as well. And these are Brian's disclosures, and of course the college never wants to take responsibility for any of this, even though they're tremendously supportive. So background again, post-op hyperamylasemia, and that was the definition that we were using 3-4 years ago. Was defined as an elevated serum amylase level after pancreatectomy. And studies have demonstrated that hyperamylasemia may be a predictor of pancreatic fistula. But at that time, there was no grading system to go with it. So the objectives of this analysis were to evaluate whether there was an association between hyperamylasemia, post-op and post-op pancreatic fistula, and to make a comparison between serum and drain amylase and their ability to predict fistula. So we used the ACF's NISQUIP pancreatectomy targeted data set. We just got the serum amylase into it in January of 2019, and we looked at the first 15 months. We now have data for a few years if anybody wants to pick up this ball. And subsequently and more recently, as I mentioned, we've added the level of the amylase in it, and we've just changed the definition a third time to the International Cell Group definition. And 2 years from now, we will have NISQUIP data in this regard. And we looked at both Whipple and distal. I think our work is not including distal pancreatectomy. And sort of a grading system based on pancreatic fistula. Grade A was no additional problems. Grade B emulated what happens with a grade B pancreatic fistula. C required reoperation, organ failure, or death. So it was almost a little bit of a self-fulfilling prophecy here. The outcomes really clinical in post-op pancreatic fistula, but all of the other typical risk group outcomes and something that we define as optimal pancreatic surgery, which means that there's no mortality, no major morbidity, no percutaneous drainage, no reoperation, good length of stay, and no remission. In other words, everything went well. Typical statistical analyses. We had data at that point in 520 patients, and remember, not everybody was measuring serum amylase at the time. A little bit more than 2/3 of the patients had ripples as opposed to distals, and at that point, about 90% of the ripples were done open, and about 50% of the distals were done open, and vice versa for minimally invasive. This is the key outcome slide. A little bit busy, but the open, if you will, this is among the patients who had an elevated serum amylase, whether or not they had a problem and how bad the problem was. And everything about the pancreatic infection, strange lifestyle conditions, they were affected, vice versa, the optimal was best if you have the odds ratios. But to me, the most important part of this study was sort of a differentiation of people with an elevated serum amylase, what the day one drain amylases, and these were pretty much day 0 or 1 serum amylases. The ROC for drain amylase is in the blue curve there. One was statistically significant, if you will, with a C statistic of 0.70. When you look at the serum amylase data, which is in the yellow line there, the ROC was 0.80, so significantly better. And when you combine the two, it was minimally greater than the serum amylase alone. So in summary, the postoperative was strongly associated with fistula and higher rates of other significant problems. Is to the drain fluid amylase 1 as a predictor of outcomes. So this didn't get published in HPB last year. That was the first time. These were the conclusions. Again, it's interesting because it's really this paper to tweak our script to include that. So this consensus will last, and as Alex mentioned, the consensus was in quotes, so there wasn't even a tremendous consensus among the world experts who came up with that definition. So let me pause there again. Nick Solemsky was involved with the session in the bigger room, but I think he is going to try and join us for the discussion here in a couple of minutes. Further thoughts, comments about this little analysis that we did comparing the serum and the drain amylase. Yes, introduce yourself and speak up. Yes, and Nick is joining us. Thanks, Nick. Perfect timing. It was less than a minute ago that I said you were coming. Too slow. For me, it's the colectomy patients where I see, the outcomes are very different with elective colectomy and with urgent colectomy, whether it be for perforation or obstruction or whatever. And the residents think that those urgent colectomy should be pushed just like an elective colectomy, and the patients, God hasn't started working and they're nauseated, and on day 5 they aspirate and die sometimes. So I think we as attendings have to be very careful not to push EUS for patients that they weren't built for. Getting back to pancreatectomy, I think the Jefferson group has done a great job. They have a fast-tracked pancreatectomy pathway, if you will, but it's only for the subset of patients who are really low risk. And interestingly, in that pathway, they do not advance the diet. They get them home by day 4, but they send them home on clears. And they have a very extensive system-wide telehealth program, and they have the advanced providers talk to the patients every day at home, even though it's day 5, 6, 7, see how they're doing and decide how to advance their diet at home. Nick, what do you think about EUS and pancreatectomy, and what do you do when the serum amylase is 300 on day 1 and 250 on day 2, and the count on day 3 is still 13,000. The C-reactive protein was up a little bit. How do you manage that patient?
Well, I'll answer the questions in order. The general question was, what do I do? And my practice is NRAS, no rush after surgery for pancreatic head resection. I think that Dr. Pitt's point about the Jefferson group is great. The MD Anderson group also has done a terrific job putting who can be treated on what I can't remember what they call the pathways A and B, low risk and high risk. So, and everybody in the room understands somebody with a pancreas cancer, pancreas duct is 9 millimeters. You can move that patient right along. Somebody with a small gland, soft duct, serum amylase that's elevated on the first postoperative day, second.
Tell me about small glands and soft ducts.
Well,
What you just said,
right. Or soft gland and small duct.
Yes.
So, yeah, sorry, I misspoke. Well, what we found is that the data that Dr. Roche showed you, and what she will be presenting also tomorrow, at what time? Did you guys mention that? 12:50. We are incorporating, Alex has done a great job incorporating post-pancreatectomy acute pancreatitis into a risk predictor. So for people who are high risk, I slow it down. So if somebody has an elevated serum amylase, elevated CLP, which we should all be measuring, I think, more frequently, then I won't feed them on the first day. I'll keep them on ice. I give them popsicles, which makes everybody happy. And then I wait and watch that. And, I have a much lower threshold to get a CT scan. If there's any, irregularity in the postoperative course, fever, tachycardia, leukocytosis, it's not coming down. So, and to me, that's really the fundamental question about where are we going to go with this post-pancreatectomy pancreatitis is we understand that this entity exists. Now, what's the next step? How's it going to help us tailor our practice?
Well, let's back. Thank you, Nick. Let's back up 2 seconds. How many in the audience think that it does exist? And how many are not so sure? Okay, does post-pancreatectomy acute pancreatitis exist? So Luke, yeah, go ahead. That's a great point and a great observation. We actually looked at our own data from IU, and again, this I'm sure we didn't have a chance to get deep into the weeds with that, but there isn't any correlation in 420 patients that we saw between drain amylase and serum amylase. So there's no question that amylase is absorbed across the peritoneum. It certainly has a half-life to show up in the serum. But when we tried to show a correlation, what I thought we were going to see is the higher the drain amylase, the higher serum amylase. But we didn't find that at all. And so, I'd also like to follow up with a question for you. Why do you think a CT is so important? Look, microphone.
I mean, I'm not a CT scans. Can you hear me?
Yeah.
But if I used to do a lot of pancreatitis work, and there's inflammation of the gland is evident on imaging.
But yeah, and that's true. And this is a sticky point, and Marcus Buchel really pushed this. I mean, the conversations among the ISGPS was incredible. The communications were incredible. I tried to show a little bit of that with some of those emails. The challenge for me is if we're going to do something about changing management, as you know from your pancreatitis work, you don't see any imaging changes for several days. We see people with pancreatitis in the ER. In fact, the APA and the recommendations for acute pancreatitis is not to get any images for the first 48 hours because somebody could have permanent necrotizing pancreatitis, but you don't see that on a CAT scan at 12 hours or 24 hours or even sometimes 48 hours. So, and when we need to change our management with a post-op situation, looking at that 3 days down the road, when you do see changes on the CT, it's not timely.
Well, just help me wrap my brain around the lack of correlation between the.
And this is the data on the slide that's on. And Chris, I'm going to ask you in a minute, do you ever see post pancreas transplant acute pancreatitis? But we'll come back to that in a minute. Okay, back to the correlation.
I'm sorry. So what's the question?
Help me wrap my brain around it. Dr. Pitt went through this slide very quickly.
We thought what we would see is that there would be correlation between drain amylase and serum amylase, and you can, these are the statistical numbers. The R value is 0.5 and 0.48. I mean, there's no statistical correlation. When you look at these data in different ways, also, I didn't include all of them here. You can see some of them are in the manuscript, where I'm certainly happy to, get as far into the weeds with this as you want afterwards, because it's interesting and very important. And your point is totally correct. Amylase is absorbed across the peritoneal surface, but the drain amylase, the serum amylase. In fact, we don't know the correlation between those two data points at all.
Question here? Comment?
Memory, the more features that you examined, how many patients had elevated serum amylase?
Yeah, that's on this slide.
Yeah, so here's the slide, 416, 15 patients, and 59% did not have evaluation of the serum amylase. These are serum amylase on post-op day 1. 2% had, this is termed POSH, post-op serum hypoglycemia, which is now by the ISGPS is POH, stop hyperglycemia. And then our definition of post-op acute pancreatitis, which now, of course, this acronym is PPAP, was 18% had the serum amylase that was 3 times the upper limit of our lab normal. And again, one of the major take-home points from this analysis was we saw increased morbidity with either one of these two, post-op hyperamycemia and post-op acute pancreatitis.
So Chris, I mean, when you're doing the transplant, you a pancreas to transplant, right?
I think that's around transplanted pancreas.
So, to answer specifically your question, I mean, you do see post pancreas transplant pancreatitis. It presents differently, right? It presents with graft dysfunction, hyperglycemia. It's not a predictor of leak per se. But I think, you know, the only analogy that I think is relevant to answer your question is that what we're trying to talk about is, you know, a way to kind of objectively measure those patients that are a little SIRSy post-operatively. And I think those are the ones that need the, what'd you call it, NRAS pathway, right? And why are they SIRSy? It's probably some element of acute inflammation, pancreatitis. I agree with Luke. It's really hard to measure like what that is, you know, by imaging or other things. But I think this is probably a proxy for that. I don't know if Nick, if you think that's what we're kind of measuring, so to speak. But I think that's what you're reacting to as an experienced clinician is like, all right, pump the brakes on this patient. We're taking the slow road because they are clearly not quite right, you know, on day 1 and 2.
Yes.
Imad from Houston, Texas. Reperfusion, and we have rejection. So it's apple and oranges, really. But I remember taking out a pancreas for necrotizing pancreatitis after transplant. So, but transplant is a different ball game.
Well, I agree completely. There's even more risk factors there than post-pancreatectomy.
Is that on risk factors?
Is that before or after?
I think it's before, a few more back. Yeah, so I think that, Chris, this is your point, and I think also getting around to this conversation of what's happening, you know, here. Is it pancreatitis? Is it SIRS? What's the and what is the mechanism behind this? And I think that this is what deserves investigation. And this is our challenge with acute pancreatitis today, which is we're not even at first base in terms of understanding what's going on with this disease. You know, we know that there's changes in the calcium transients at the acinar cell level. We know there's zymogen and lysosome co-fusion. We can measure that, but who gets this and why? You know, Saxon Connor, who was the first guy to actually publish about this over 10 years ago, you know, said this is probably an ischemic problem. Sure, there probably is some ischemic problem. We're surgeons, so we like to think there's probably a technical component. There may well be. What about the factors in the pancreas, either at the glandular level? You know, clearly everybody who's studied this has said soft gland and small duct are higher risk for PPAP. Where is it at the cellular level or the molecular level or the genetic level? You know, I think what we're learning from David Whitcomb's work is that there are clearly people who have genetic predisposition. You know, this is why not everybody who drinks heavily gets pancreatitis. This is why there's only a fraction of people who have hereditary components. So, and what about perioperative therapy? You know, maybe the ERAS is we're giving people less fluid, and so that's you know, that's a different piece. What about the narcotics that we give with bowel dysfunction and increased pressure in the bowel? I think there's a lot of way to go. There's a lot of room to evaluate this problem.
Alex, Nick, thank you very much. Thank you very much. It's been a great day. I think there's a party soon.
Yes. Take care. Bye-bye.
Sorry, it's stress that. This is good. It's a great discussion.
Yeah, no.
I had a good audience for this session.
Who's the guy who's talking in the back?
Chris Simon.
No, I know Chris Allen.
Yeah.
Luke.
Oh, Luke's showing